Hello, and thank you for joining us for Wisconsin Parkinson Association's educational video series. I'm Jeremy Otte, Director of Outreach and Education with the Wisconsin Parkinson Association. WPA provides hope, community, support, and resources for people with Parkinson's disease and their loved ones. Today, we are talking with Dr. Katie Spangler, a neurologist with Marshfield Clinic in Wausau. Dr. Spangler and I are going to discuss common topics associated with you when you are newly diagnosed with Parkinson's disease and other questions you may have. Welcome, Dr. Spangler. Thanks for joining us today.
Thanks for having me.
Not a problem. Can you tell us a little more about yourself and your background?
So I've been practicing now as a movement neurologist since about 2009. I've been with the Marshfield Clinic since about 2013, where I pretty much just do clinical work at this time in clinic, and I have a primary movement disorder practice, of which is mostly comprised of Parkinson's disease patients. Prior to my working life, I was a fellow. I did a movement disorder fellowship down at Medical College of Wisconsin, which is also where I did my residency and medical school.
Well, thank you. You're up in Marshfield Clinic in Wausau. So can you provide us a little overview of common motor symptoms associated with Parkinson's disease?
So we talk about the 4 cardinal motor features of Parkinson's disease. They consist of bradykinesia, or slowness of movement. The second would be resting tremor, and typically it's asymmetric, which just means it's more on one side than the other. The third cardinal motor feature is something called rigidity, which is a muscle stiffness. It's not a bone stiffness like arthritis, as we see in age, but it's more of a muscle stiffness. And the fourth symptom we see is something called postural instability or balance. So those are the 4 cardinal motor features of Parkinson's disease. Obviously, we see a lot other features, but we kind of go along those 4 cardinal motor features. And typically, if we see 2 out of the 4, and especially if one of those 2 is the asymmetric or one-sided resting tremor, it's most likely going to be idiopathic Parkinson's disease.
So if I come to the clinic, my primary things, you might have Parkinson's disease, I come to visit you. What are some of the tests you might run me through to see if it is Parkinson's disease or looking for those cardinal symptoms?
Okay. So a lot of the diagnosis, or I should say still the diagnosis, is still what we call a clinical diagnosis, which means we don't have a blood test or a scan or anything that specifically will give you the diagnosis. So it's still based on clinical grounds, which means that we diagnose based on history. So it's how long your symptoms have been going on, you know, what kind of things have you noticed day to day, but also objectively, we use a scale. It's called the Unified Parkinson's Disease Rating Scale, and it's a scale that we use in clinic, and that, at least the part 3, I should say, of it. The part 3 is the motor scale, and that part really looks at those 4 cardinal features that we talk about. So again, that bradykinesia, the rigidity, the resting tremor, and then that postural instability. So it's a scale that we movement neurologists use.
So when you say there's no blood test or scan, I've talked to people who are diagnosed that, oh, I had a blood test done, I had a scan. Are you doing that to rule other things out in the diagnosis, or is there a reason that maybe they've gone through those before the diagnosis?
So yeah, if there's something about the history or about the exam that just doesn't quite sit right, we may do additional blood work, or we may do something like MRI scans or something like that. And again, but those are just to rule other things out, as there's a lot of things that can look like idiopathic Parkinson's disease, but could be something else.
Thank you. That's something that comes up a lot at support group for people to ask that. I think it's important, this distinction for them to understand. You've touched on it a little bit, but if I come in, new patient, you talked a little bit about the asymmetrical symptoms, but are there other benchmarks you're looking for that tells you this is probably Parkinson's disease versus something else?
Well, so as I mentioned, there are things that can look like Parkinson's disease, but are not Parkinson's disease. We call them different things like atypical Parkinsonism or Parkinson plus syndromes. So what I would call maybe red flags that would indicate it's not just what I say bread and butter Parkinson's, you know, early onset memory issues, eye movement abnormalities, significant passing out, or significant what we call autonomic or non-motor symptoms sometimes, can sometimes signify that this may not be just idiopathic Parkinson disease.
When you say early memory issues or cognitive issues, can you expand on that a little bit? Because I have people all the time, they're like, oh, I forget where my car keys are. And I always tell them, well, that's not what people are looking for, but can you maybe touch a little more what it is you're looking for in those incidents?
Right. So it's a matter of degree, but it's also a matter of content in terms of what people can't remember. There are certain things that are age-related things, such as forgetting people's names. That is very much an age-related thing. So if someone comes in and complains of those things early on, I wouldn't necessarily be concerned. However, if people come in and they forget how to use the phone, or they're having hallucinations, or which again are seeing things that aren't there, or hearing things that aren't there, those kind of are red flags to me that maybe this might be something else.
And that's a big distinction. I'm glad you kind of went into that a little bit. The last one you kind of talked about, before I get into postural instability, you talked a little bit about resting tremor. I have people a lot of times they confuse what a resting tremor is versus I'm taking a drink of water and my hand is shaking, or what non-essential tremor looks like. Can you maybe define a little more what resting tremor looks like and what it is you're trying to determine when you're talking to somebody?
Right, because it's not very common that someone's going to come in and go, I have resting tremor. So people are going to notice, so a resting tremor is going to be when your hand or leg, but more often a hand, but we do see it in the leg or the foot as well, but it's in a resting position. And so it can be when they're just having their hand on their lap and they notice it shakes. I have heard people a lot of times when their hands are on the driving or on the wheel and they're driving, it may shake. And again, your brain will interpret things as resting if it stays in a certain position for any period of time. So sometimes people also with resting tremor will notice a tremor when they're holding onto their phone. You first pick up the phone, you're fine, but the longer that you hold it there, the more it may shake. So though that would indicate more of a resting tremor. A non-resting tremor, someone may notice a tremor when they're trying to eat or trying to bring something up to their mouth, or when they're writing. Those are all tremors that are not primarily resting.
Thank you. I think that's a good description, because I've heard a lot of people go, well, what is a resting tremor? And I think you really hammered home what that is. Thank you. So the other one you talked about is postural instability. Can you maybe go a little more into what that looks like? So I think there's a couple of different variations of postural instability, whether it's maybe stooped posture or backwards. If you can maybe expand on that a little bit.
So again, we put a name to something and we see something in clinic, but day to day, people aren't going to come in again and say, I complain about, I have some postural instability. So in history, what it might look like is, so people might have trouble getting up and out of chairs. They may have trouble turning. They may have that stooped posture, but they also may be coming in just with falls. They may lose their balance and fall backwards. So those are all signs in the history that the balance might be due to something like Parkinson's. That being said, there's a lot of things I always tell my patients that can lead to balance issues. Everything kind of has to be in alignment: your eyes, your ears, your nerves, your muscles, your spine, your brain. So balance can be quite complicated. And so it's really good to get at, well, what kind of things cause the balance issues? What kind of things do you have to do to notice your balance issues? Because I mean, a lot of people can come in and just be imbalanced, but it's not Parkinson's necessarily. So some of those things I mentioned in history can kind of indicate there might be some postural instability that falls in the Parkinsonism category. On examination, what we look for is, again, how do they get up and out of a chair, right? We have people cross their arms, they stand up, how quick are they to get up? And then their walk, how much do they swing their arms? How wide is their gait, right? Is their gait cadence? How do they turn? Do they tend to what we call en bloc turning, which is just kind of a shuffly, like you're moving like a block of wood and you're turning. And then we also do a balance test where we tap the shoulders back, and typically a person without postural instability would take about 1 to 2 steps backwards and correct themselves without problem. But people with postural instability, you tip them backwards and they either continue to what we call retropulsion backwards, or they even fall into your arms. So that's how we kind of look at that component in the clinic or on examination more objectively.
Thank you. And I think that explains why you always make them get up and walk maybe 10 or 15 steps. I've had people go, why do they do all that and then have to walk? And I think that probably explains why very well.
Yep.
The last cardinal symptom I'm going to touch on before we go on here, rigidity. I think rigidity is one of those hidden ones that you don't see. I mean, I can see slow movement. I can see a stooped posture. I can see a tremor. But rigidity, maybe with the naked eye, I can't see. So can you explain a little bit what that rigidity is and then how, as a clinician, you're looking for that?
So patients with rigidity sometimes will notice or complain that things feel stiff. They also may have cramping. And sometimes the cramping happens early in the morning period. It's waking them up where their feet are kind of curled or cramped. We call that dystonia, but that can be a sign of uncontrolled rigidity. And again, as I mentioned earlier, rigidity is a muscle stiffness. It's not a bone stiffness. And so the muscles may feel tight, cramped, even fatigued because they're so tight. On examination, how we monitor or how we test for rigidity is just basically passive movement. So we have patients just kind of passively move their arms or passively move their joints, and we can feel that rigidity on examination.
Thank you. So I just came in, we've done the whole, the UPDRS, you've given me the exam, you've made the diagnosis. What are my next steps? What do you recommend for the patient and family now that we think it's a Parkinson diagnosis and we're moving forward?
Yeah, so as long as I don't see any atypical features or red flags, I typically don't get imaging on all my Parkinson patients. So just by not getting an MRI doesn't mean you didn't get the full workup. I rarely actually get MRIs if clinically it points to Parkinson's disease. So if it points to Parkinson's disease, I usually have a pretty, I think, lengthy discussion about what the diagnosis is, because I find that a lot of people many people come into the office already concerned about it, or have already heard about it, or somebody told them about it, or they read about it, or they knew somebody about it or with it. So they have a preconceived notion of what it is. And so I try to first ask, or I can tell at least where they're coming from. And a lot of people, it's that look of, oh my gosh, I just got diagnosed with cancer kind of look. So I try to calm their fears about it, first of all. And so I try to understand where they're coming from. What are their fears about this diagnosis? And so I try to individualize care that way. But then I also just generally talk about the disease and really what the risk factors are, because some people come in thinking that they did something or didn't do something that put them at risk. So I put them at ease in terms of that. Or I should say, I hope I put them at ease about that. And then, teaching just really about even the science of the disease, I think, because once they kind of know what the science is behind it, what's happening in the brain, I think people, knowledge is always power to me. So I give them that knowledge. And I often emphasize that it still is very adequate to say that people don't die from Parkinson's disease. It is something that you live with. And so I often talk as a team and say, listen, we're here to work together to live your best quality of life that you can live with this disease. And of course, I bring in things that they can do to take control and to be more in control of their disease, such as exercise, eat healthy, all those things that we should be doing anyway. But I usually, that first office visit, talk about those things.
We've talked to the person's diagnosed. What are some of the tips or things you talk to the care partner about that maybe help them ease their mind a little bit as they're going to start this journey?
Well, again, they come also with usually their bag of questions or concerns. And so I try to really understand what their concerns may be, because they may actually very different than the patient, or they may be similar. So just trying to understand what they're bringing to the table. I think, the question I always get is, well, what's to come, or what can we expect? And I really try to emphasize both to the caregivers that this and to recognize that the caregivers, this isn't just a disease of the patient, but it also obviously affects the care partners or the caregivers. And that I'm here just as much for them as I am for the patient. You know, and each caregiver has their own, like I said, set of issues because each patient is very, very different. I talk about the different flavors of Parkinson disease. There's just so many different flavors. And so one care partner may not struggle with a certain issue and the other care partner may struggle quite a bit. So it's really just individualizing their care and making sure that we're all a care team.
I think you said two important things there is letting them know you're there for them just as much as the patient. I think that's very important for a care partner to know they have you as a resource. But then I think the last thing you said is really important and I want to maybe touch on being part of the care team. When they're diagnosed with you, the care team is obviously the patient, the care partner, but within the clinic, what part of the care team do you guys have there that you support them with that is very important as they start their journey with Parkinson's disease?
Well, we work really closely. Here at Marshfield Clinic, and I think each place is different, but we have myself. We also work with advanced practice care. So we have a nurse practitioner who is movement disorder trained. We also have devoted nurse and we have a devoted MA to our team. So it's us for providing the medical care, but then outside of that, of course, we have our physical occupational therapists and speech therapists as well. We also have social work available should there be those issues that need to be addressed.
And I think it's important to highlight the outside the clinic, the PTs, the OTs, the speech therapist, the social worker, that it doesn't end with your doctor's appointment. There's so much more going on. And no matter where they are, I know Marshfield Clinic has a lot of outreach in areas, as do other clinics. I think it's really important to touch on that. As they work with you through the journey, you know, you're the clinician. What are things you ask them to prepare when they come back for follow-up appointments? Things that maybe the patient should be considering as well as the care partner that are going to help you maybe manage their care a little better and help them as they go along day to day.
So depending, you know, I usually see the Parkinson patients about every 3 to 6 months, some every 12 months, depending on their disease. But, you know, you think you're going to remember in 3 months what you want to talk to the doctor about, but that's not always the case. So I really encourage them, well, first of all, not only to call in the meantime if there's something, but let's say it's not urgent enough that they feel the need to call, is to really make sure and write down both positive and negative things that have happened in the last 3 months or 6 months or whatever, so that we can make sure and make the most out of that visit. You know, I would hate for a patient to wait a few months to be seen, and then they forget to ask what they really wanted to ask. So I usually try to encourage people to write down their concerns and kind of not keep a log per se, but keep those things on paper so they can bring them to their appointment.
And I think that's, whether it's a log or how you do it, I know when I talk to support groups, I always tell them use your smartphone. There's a note section. Just like you mentioned, I have gone to the doctor before and went in for one thing, talked about another thing, left and forgot to actually talk about what I made the appointment for. So it's important to write that down once in a while to have those discussions because it is hard to remember week to week versus day to day. As they're working with you, you know, we talked about the PTs, OTs, social workers. I know there's some support groups, exercise groups, and more growing within your area. How much do you encourage them to get engaged with community resources that are out there, such as support groups and exercise groups when possible?
Well, so not to throw a pitch out to the WPA, but we do actually. So at diagnosis, usually we hand out a folder, and in that folder is resources for exercise class, for support groups, for educational resources. We often put things in there about, you know, different medications, surgical options, even though that's not a discussion we have, but it's just kind of like, I don't want to say, but an initiation folder almost. So, and so right at the gate, we introduce that stuff. And I really emphasize as part of that initial discussion you know, that again, try to have the patient be control of their disease is to stay active. And I try to tell them, so this is how you can stay active. Look at these resources, you know, and those types of things. So we give a blue folder out with the WPA and all that wonderful information out actually at diagnosis. So.
Well, I didn't mean for it to be a plug, but I do appreciate that. And I think we found, and I think part of the discussion, the blue folder came about when we talked to the medical advisory committee, which you're a member of here in Wisconsin, where we have 8 doctors, majority of them movement disorder specialists. And when somebody does get a new diagnosis, it can be overwhelming. So to have a resource to take home and refer to later down the road and refer back to when they talk to you, the feedback we've had is very positive, and it sounds like you've had some of the same feedback from the patients you've worked with.
Yes, we very much have gotten positive feedback about it. Again, I practice in rural, central and northern Wisconsin. I mean, I have patients coming down from the UP to see me, and you know, they don't have exercise groups up there necessarily or things, but this is a way for them to get plugged in, you know, to feel like a community basically. So.
Well, I think you've covered a lot of the questions we have been given to us before by individuals, Dr. Spangler. Is there anything we haven't touched on that you think, you know, for somebody newly diagnosed or a care partner newly diagnosed, these are things they should really, really glom onto and take hold of as they work with their clinician going forward?
I guess I would just, you know, add just to make sure that you're communicating with your healthcare provider and that, you know, you're letting them know all aspects of your disease and what you're struggling with. Because I often say to my patients, if you know, if I don't know, it's like a mechanic. If I don't know what's going on with the car, I can't begin to fix it or help. So, you know, you're the information. You have to bring it to me so I know what to help you with. And again, I just always want to emphasize to patients that it's a very individual disease. There's a lot of different flavors to it. And although we're human and it's natural for us to compare ourselves to others, we really shouldn't, you know, unless you're going to take a positive spin on it, but because everybody is very, very different.
Very well said. I think communication and the fact that it is so different. You can go to a support group where 10 people in the room all have been diagnosed about the same time, and all 10 of them have very different symptoms, experiences, and journeys. And I think that's really important for people to understand. So thank you for highlighting that.
You're welcome.
With that, Dr. Spangler, I'm going to thank you for your time today and providing information and resources for people recently diagnosed with Parkinson's disease. While we are all currently practicing social distancing, please check in with Wisconsin Parkinson Association frequently. We are regularly updating our website and Facebook page with exercise classes, educational videos, such as this one, and lots of other resources for you to stay safer at home. You can email us at mail@wiparkinson.org with future topics you would like to see covered by our local experts. Hopefully, you're finding these educational video series beneficial. WPA relies on donations from individuals like you, so please consider a gift today at wiparkinson.org to continue to keep all WPA programs and services free now and in the future. I'd like to thank again Dr. Spangler for being our guest today. Thanks to you for joining us. Please take care and have a good day.